This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of prehospital care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs-bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're looking at the evolving picture of shock in major trauma. So something slightly different today on the podcast. We're going to look at a case review from Prehospital Care with Dr. Michael DeFilippo. So we are diving into this case as it really challenges us to think beyond protocols and beyond physiology, really, to look at pattern recognition and decision making fundamentally under pressure in probably one of the most tricky cohorts in prehospital care. So just to set the scene for this case study, and just to say before we go into it, this is a fantastic Substack blog that Michael's put out. So we will put links to the Substack blog in the show notes. But just to set the context, it's a summer afternoon. The emergency control room dispatch sends a crew to a high-velocity motor vehicle collision, and it's a sedan travelling at speed. It's landing to the rear of a parked lorry or dumper truck on a rural highway exit. So multiple callers report a single driver trapped, initially unresponsive. So as units respond, the call is upgraded. It's now an unconscious patient with entrapment and a long extrication ahead. So the battalion chief, or indeed the first responders on scene, carrying blood products, is started 15 minutes away from the call, so they are en route to the patient. So on arrival, the crew finds a 34-year-old male driver severely entrapped. So the engine block has been displaced into the pelvis of the patient. So he's now conscious, but he's agitated and in significant pain. So he admits to alcohol use, reports speeding of up to 100 miles an hour prior to the collision. So his initial vital signs don't look catastrophic on initial view. So his blood pressure is 114/76, but the details fundamentally matter. So he's tachycardic, pale, clammy, and he's slow to respond. So access or IV access is gained, analgesia is given, and the extrication takes approximately 12 minutes. So as the call progresses, the story slightly changes. So during transport to the hospital, the patient deteriorates. He becomes paler, more diaphoretic and or sweaty, increases in lethargy as well. So radial pulses weaken, breath sounds disappear on the right, and what initially looked like a stable patient begins to self-declare himself as an evolving hemorrhagic shock patient. It's also complicated by a developing tension pneumothorax. So blood is started, TXA is given, needle decompression is performed on the right with an audible release of air. A pelvic binder is applied, and critical decisions have already been made to bypass the nearest hospital and commit to a larger level 1 trauma centre. So the patient arrives to that centre, hypertensive, tachycardic and critically injured, but still alive. So we're really going to dissect that case with Michael in the case and really draw out some of the key learning points. Michael, welcome to the podcast.
Thank you for having me, and I'm excited to be here.
It's fantastic to have you, actually. Michael, just before we dive into some of the questions and really dissect this case, could I get you to maybe just speak to your experience and where you practice now?
Absolutely. Yeah. So currently, I am an assistant professor of emergency medicine and public health at Washington University School of Medicine in St. Louis, Missouri. And out here, I wear quite a few different hats. My primary hat is as an EMS physician or a pre-hospital physician. The majority of my time is spent teaching EMS crews, responding to 911 calls, complex interfacility transports, things along those lines. Then I also split my time working clinically in the emergency department in a teaching role with physician residents trainees. I forget what you guys call them there overseas, but lots of different terms for that. And then the last bucket I wear is as a researcher. So I do a lot of research around time critical diagnoses, systems implementation, and then around obstetrics in the pre-hospital environment. Prior to all of that, I also worked as a paramedic for about 10 years in the New York City area. Worked primarily urban to suburban, did a little bit of rural. Then got bit by the bug of wanting more education and decided to go back to medical school. That's where I say I lost all my hair. And I did have a beautiful head of hair when I was working as a medic, I like to say. And so I did my medical school training at Rowan University, which is right outside of Philadelphia. I did my specialty training in emergency medicine at New York Presbyterian, Columbia, and Cornell hospitals based in Manhattan, New York City. And then my subspecialty training in emergency medical services and pre-hospital medicine at the University of New Mexico. And there I worked very closely with Albuquerque Fire Rescue and also did some wilderness medicine with the Grand Canyon National Park Service before finally settling down here in St. Louis. So that's my 2-minute spiel about who I am.
This and that's fantastic and wide ranging and actually it shows actually in the Substack piece. We will put the links in the Substack piece so listeners can go away and read it in slow time because I think what it does is it really illustrates the way you approach and all your lived experience and the way you approach these complex trauma patients and the evolving picture. And so let's just dive into it actually because
Sure.
to your point, in pre-hospital care, Michael, and I'll get you to speak to this actually. Sometimes the picture on scene has got some fundamental key attributes which can lead you down the actual injury pattern to the patient. So, high speed motor vehicle collision into a stationary object with entrapment. There's that steering wheel, there's a dashboard, but just walk us through from your mind as you fantastically open up in the Substack piece. How does this case really conform to major trauma? What are some of the mental models of injury patterns that you look at when you approach this case?
Sure. Yeah. So whenever I hear dispatch like that, lots of things are going through my mind. Fairly similar. I always make the analogy to when we're getting a call ahead in the emergency department. We're mobilizing resources. We're sort of thinking about what could all the potentialities be. And I think about that too with dispatch information. So in particular for things like this, stuff we already heard going to the scene or this crew already heard going to the scene was that it was a high speed NVC. And really when I think about that, it's kinematics, not necessarily, everyone's always like, oh, these cars are getting better, people are less injured, and that's virtually true for most of those things. But the kinematics, the energy transfer, the higher the speed, so if you double the velocity, it essentially quadruples the energy of transfer that's going into there. So significantly higher speeds, like a 50 mile an hour versus a 100 mile an hour accident, could be quadruply as bad as far as the energy transfer that goes, not necessarily doubly as bad just because the speeds double. So whenever I hear about, in particular, that mechanism, right, high speed versus a stationary object, like you were saying, stateside we say dump truck, I guess you say lorry over there, but a very fast vehicle into something stationary, things I think about is sudden deacceleration versus a fixed object, prolonged entrapment. Now I'm thinking there's lots of different collisions going on. So classically, the different styles of collisions we're taught is obviously the vehicle and object. Then we think about the occupant into something interior of the vehicle. And then we think about those internal organs then colliding with something rigid within the body. So lots of different potentialities for bleeding. Then there's that entrapment layer on top of it. So other things I'm thinking about, right? So time-dependent crush physiology or pathophysiology is something I get concerned about. We always talk about crush syndrome. We're always familiar with crush injury, right? You may bang your finger against something and temporarily crush it. But that crush syndrome, when something is crushed and then held in that position for a long time, is a whole different pathophysiologic cascade. So when I hear this, things I'm thinking about, even back in my paramedic days, was this is quite a significant mechanism. And I know I'm going to be doing some work, right? It's not just one of those little MVCs I'm rolling up on scene, eyeballing everybody, doing my virtual vitals assessment and seeing how sick some patients are and taking them to the hospital. I have to anticipate what sort of injuries I'm expecting. And that's sort of what I'm doing ahead of time. Is this mechanism significant enough where I think I'm going to have to do some procedural interventions, right? So, IO, not just an IV, some more elevated things. Am I going to need to do finger decompression? Am I going going to be needing to do some sort of stuff on the scene. And then blood realistically is the other biggest thing to operationalize in our system. So all of these are sort of going through my head based off just the dispatch information and my anticipated injuries by the time I'm arriving to the scene. So I always like to say I make some preliminary resuscitation plan just from the dispatch information. So by the time I'm walking up to the vehicle or walking up to the scene, I already know what I'm worried about and I can adjust that plan realistically in real time.
No, absolutely. And you make some great points there. One being that there's architecture and real estate within the cabin of a lorry or indeed a car, which, a bent steering wheel is, that steel rod throughout a bent steering wheel to bend that with your
Hmm.
chest. There's significant energy transfer there. And to your point, as a dashboard comes in or closes in on a patient, your pelvis is exposed, and any injury above and below probably infers there's an injury to the area itself, so to the pelvis. But also to your point, if you the subtlety and nuance of maybe some bruising and mild diaphoresis lead you down. You can be falsely reassured by a blood pressure because there is. To your point, the difficulty and challenge of pre-hospital care, and I'll get you to speak to this, is the evolving nature of what is, like you say, a crush syndrome and crush physiology, whereby something's been significantly crushed and held in place, and then that release, starts to, especially with the pelvis and indeed the right side of the chest in this case, starts to an evolving pneumothorax and then a tension pneumothorax, which is held under tension, starts to move into the chest and preclude any afterload, any preload, and starts to fundamentally interfere with cardiac output. But also, you release that patient from that compartment, from that driving compartment, and that and the great vessels throughout the pelvis just start to unopposedly start to bleed. All which is occult, so you can't see this. This is
Hmm.
occult bleeding and a occult tension in pneumothorax. Just walk us through those, just not getting trapped into those normal numbers or that normal physiological picture.
Yeah, so I think that's a great question. This is what I spend a lot of my time teaching on, actually, when I'm talking about trauma. So I refer to it sort of as the normal BP trap, right? So you walk on scene, you have this major trauma, or even a medical patient, right? And you're like, the patient looks a lot sicker, the mechanism seems a lot worse than the patient I have in front of me. I have a blood pressure that's normal. Okay, wipe the sweat off my brow. We're going to have an easy drive into the hospital. Absolutely wrong. I tell people retire the systolic blood pressure as a standalone trigger. You really can't use it. There's really I use a lot of different things on scene for a dynamic shock assessment, but the three things I really look on in particular are the shock index, the patient's skin color, temperature, condition, the mental status, and then serial reassessments to sort of build a trajectory. One vital sign is just a single data point, despite being multiple different pieces of data, right? You may have systolic blood pressure, heart rate, SpO2, all these different things. That's still just one data point on a very long trajectory of our patient's transport. So I always say trend your vital signs, trend your assessments, because there's lots of things that you can realize, especially with that shock index, in particular for looking up developing shock. So the pressure may look fine, but like you were saying, it's because the body is paying it for it in some way, shape, or form. We're paying for it with elevated heart rate, vasoconstriction, clamping down on skin perfusion a little bit. It's not until much later that we see these occult shock signs become overt shock signs, when in reality, there were warning bells there all along, sort of cluing us in if we were looking for them.
You emphasize the shock index. If you could walk us through that, Michael, and then indeed how you integrate that without it sort of slowing you down on scene.
Sure. So I know this is a podcast about trauma, but just a general lecturing point. So I actually utilize the shock index on all of my patients because it's just so versatile. So what is the shock index? It's a fairly simple formula. I'm terrible at math, but luckily we have smartphones readily available to us. You just take their patient's heart rate and you divide it by the systolic blood pressure, and that spits out a number to you. And that number really can tell us, is this patient okay? Are they developing occult shock, or Are they actually in pretty significant shock, but just their heart rate and systolic blood pressure are compensating? So you do that formula and it's going to spit out a number, usually on most of your stable patients around zero point 0.5 to zero point 0.7, and that's normal. We really start getting concerned when that number is around zero point 0.9 and really getting above 1. So if you remember one number only, it's just the number 1. When that number gets above 1, especially when we're talking about in the setting of trauma, especially clinically significant trauma, what that portends and what all the studies look at is the need for mass transfusion. So for folks who may not be familiar with what mass transfusion protocol is, most hospitals, especially stateside, and I know also overseas in the UK, or that may be stateside for you and I'm overseas, but wherever you're at, most hospitals have a mass transfusion protocol. We recognize a patient has bled so much, usually from the setting of trauma, sometimes from other things, that once they have bled so much, we recognize they're going to need lots of blood product in a very, very short period of time. So I'll just give you an example of how that works here. Let's say we do the shock index on a patient with a gunshot wound that's bleeding. That shock index comes back at 1.1, even though their heart rate and their systolic blood pressure may be slightly normal to a little bit abnormal. That tells me that within the next hour, 2 hours, this patient's going to need a lot of blood product. So I'm usually activating the mass transfusion protocol based off that number. And what does that do? It stops the lab in our hospital from sending blood product to anybody else and diverts every single piece of blood product to that single patient because it is recognized that that patient is in such extremis. So that really gives you an idea of how much you can glean just from this simple formula. And the fact that we haven't been using it routinely in the field in identifying occult shock, to me, is a disservice to our patients. So again, the teaching point here is to use it pretty much on all patients. It's a hard stop for me. If I calculate a shock index on a patient, I do it on everybody, and I don't always whip out my phone to get the exact number, but really what I do is the heart rate so off from the systolic blood pressure that I should be considering some element of shock. Even if I'm not considering shock and the patient looks totally fine in front of me, it's a hard mental stop for me, and I go, okay, their shock index is around 1. I really need to take a pause and think for a second. Is there any way, shape, or form this patient in front of me could be developing shock, or shock could be thrown into the picture even though I haven't thought about it? If not, then I can sort of put that anxiety to rest. If so, then that totally changes the game, right? You've recognized now that you have an occult shock patient in front of you or a rapidly developing shock patient in front of you, and it changes your resuscitation strategy significantly, I would argue. So a patient like this, I included a graph in that Substack there, but a patient like this had a fairly high elevated shock index that whole time. And this crew, I think, did a fantastic job of recognizing that and really changed the aggression of their resuscitation strategy right from the get-go. So just really to take home point from that. So in the back of the ambulance, we don't really have a lab, right? Or at least not yet. Maybe in the near future, we'll have a lab. But we have a heart rate, we have a blood pressure, we have the ratio in between them, and we have this clinical picture that we're taking in. So that ratio, that shock index, tells us a lot more than that single number alone. And trending that shock index also tells us, how is this patient responding to therapy, or does this patient need some more aggressive therapy?
Yeah, all of which makes sense actually, absolutely. But so you denote, the potential for a shock bundle because to your point, Michael, there's two things going on here. There's obstructive shock, and that might be air in the wrong place between the parietal and the visceral pleura, and indeed there might be hemorrhagic shock. So there's a volume issue as well. So there's air in the wrong place. There's blood volume in the wrong place as well. But could I get you to speak to that, that shock bundle in the back of a moving ambulance that can really give a package of care pre-arrival to the hospital?
Sure. Yeah. So what are things we know go off in shock, right? Or rapidly can decompensate in shock. So shock index is one of them, and we've talked about them. Other things I look for, my default shock bundle are end tidal CO2, right? Seeing if there's developing acidosis. Mental status. Mental status is your most sensitive finding sometimes, right? You show up on scene, and I always like to teach my physician trainees this and my EMS clinicians this because it has got me more than once. Anxiety is a big one, right? Anxiety can sometimes be the earliest sign of altered mental status, and we always poo-poo it as, oh, you were just in a big accident, calm down, everything's okay. their body's firing off catecholamines left and right because there's some occult hemorrhage going on, right? So the first thing they're going to feel is the physiologic effect of that, which is going to be anxiety. So don't poo-poo anxiety initially, especially when there's a decent mechanism associated with it. And then lastly is skin perfusion. I'm not trying to be that guy like pushing my glasses up. I just actually published on this, but I did actually just publish on this in Air Methods Journal, looking at the Andromeda 2 shock trial, which was really focusing on sepsis patients, but similar analogous thing here. We can see so much from skin perfusion, capillary refill, putting a hand on the patient. I'm always touching a patient when I get on scene. You know, this idea of we're so advanced, we don't need to do foundational skills like palpating a radial pulse, palpating our patient, getting a good palpatory skin assessment. That can tell you so much. A patient may visually look okay, but you touch them and they're ice cold. That may sometimes be the earliest sign also that you're having shock. So the reality is that we're trying to formulate our gestalt, right? So an experienced clinician may recognize a lot of these things showing up on scene, look at the patient and go, oh, this patient's really sick, right? And the newer clinicians like, how can you tell that? So it's really trying to objectify a lot of this gestalt that more senior clinicians have. And this is sort of how I've operationalized that in this sort of shock bundle. So, you know, it also provides a little bit of shared vocabulary on scene too when I'm talking to my crews, and a lot of the physicians that work with me, especially my trainees, know these are the things I'm looking for. So it's like, okay, how's our shock bundle doing? What are we doing when we're evaluating this patient? And is our gestalt actually objectively verified what we're seeing on the scene? We see a sick patient. Now let's investigate further and see if the objective data matches those things. So that's sort of what I'm going through with that shock bundle, is just very easy data points we can glean on scene, capturing them in series of time and trending all of those as a trajectory in lieu of having more of the advanced therapies like imaging and lab work in front of us.
Yeah, and I agree with that. And I think to your point, it's about the subtleties, you know, that subtle elevated respiratory rate, that either the acute agitation or indeed the progressive agitation, you know, and it is that hypoxic, it's fundamentally a sign of hypoperfusion
Hmm.
to the brain and or otherwise. But to also to your point, and you made this earlier, and I think it's a fantastic point to labor on, no number in isolation is of value. It's about that trended data. So if you've got a blood pressure cuff, turn it on to auto cuff, or you know,
Hmm.
1 minute cycles, or you know, gleaning as much information, putting the ETCO2 on, you know, or putting the saturation probe on. You know, maybe not listening to the chest if it's a loud noisy scene, but you know, getting a capillary refill time, a central capillary refill time, you know, not discounting just a mild bit of diaphoresis
Hmm.
to the brow, and just looking for these subtleties, and then you can start to see, you know, an acute change before your eyes in the patient.
Yeah, so just as you alluded to, it's a very complex thing, right? You know, it almost seems as if they're competing guidelines or competing protocols, right? On one hand, we want to do permissive hypotension. On the other hand, we want to perfuse more, right? So, but what I would really say is like it may appear as competing protocols on paper and overtly, but they're actually calibration of that same dial. You know, both of them really seem to say, and both those guidelines, yes, we want to try to reduce the amount of bleeding with permissive hypotension, but really at the end of the day, if we resuscitate someone and they don't have an intact mental status, then was it really, you know, all for naught? So, you know, I have a fairly low threshold on what I consider an unreliable neuro exam or what could be a traumatic brain injury, especially in the pre-hospital environment. So I really personally follow the National Association of EMS Physicians position statement over here, not just because they're my parent organization as an EMS physician, but it's just a well-researched article and guideline, as well as the BTF pre-hospital traumatic brain injury guidelines. And what do those say? Based off our best look at the evidence, we know that we want to try to maintain cerebral perfusion pressure, or CPP. So, just as a quick refresher for what that is for everyone, it's the mean arterial pressure minus the intracranial pressure, or the MAP minus the ICP. Again, spits out some random number for you of about 60 to 70 in your ideal patient. What that tells us is when a patient's in extremis, right, in shock, that MAP drops so low that ICP range or that CPP also drops really low. And we don't want a lot of deleterious effects happening in the brain based off of that. So, who do we recognize as an unreliable neuro exam in the field? any sort of alcohol use is a low threshold for me. And I'm not talking about the guy who's like, oh, I had a drink last night and I'm doing okay, but the patient who appears floridly intoxicated, states they may have been drinking today. If there's any sedation already received by the patient, right? So, a common issue for me as a physician, and when I was doing flight, and same thing I'm sure for some listeners overseas there with flight programs and intercept vehicles, some agencies may already be doing some work before you get there and you can do a detailed exam. So if the patient's sedated, you're sort of going off secondary info. Is the patient paralyzed from some injury already? Are they postictal from a seizure? Did they have a brief arrest and now they're altered? So lots of things can compound this. So any sort of altered mental status, and I don't have a good explanation for it, or when you look at the data, most people will tell you a GCS less than 12. GCS is not the most sensitive tool for really assessing traumatic brain injury in the acute field setting, but it does have a good amount of literature behind it. So any sort of altered sensorium have a low threshold, or if the patient has a GCS less than 12. Then the question becomes, what do we do for these patients? So try to maintain that systolic blood pressure around 110. I have a huge thing about systolic blood pressures too. Sometimes in the field can be a little unreliable, especially with our automatic cuffs. So, sometimes I also tell people just aim for a map of 80. More often than not, the mean arterial pressure is actually the more accurate number we're getting from a lot of these auto machines. A quick nerd alert sidebar, most people may not know. So if you're using a automated cardiac monitor or an electric cardiac monitor, most of us are using them with an automated BP cuff. It actually detects a map first and then uses calculations to give you a best guess of a systolic and best guess of a diastolic blood pressure. When patients are in extremis and shock, again, this is all anecdotal. I don't really have any studies to share of this, but just in my experience, I find those values don't really correlate as well, let's say with like an arterial line if I'm in the ED or doing a critical care transfer. But one thing that does translate well is that map. So if you're noticing maps are being more reliable for you, then I always teach too, what's permissive hypertension goal in a shock patient with a TBI for a map is aiming for about a map of 80. Really the big take home points, right? So then it becomes, and I've been in critical care transfers of this too, right? I have a map of 79. What do I do, right? Do I press the patient up? Do I, do all these things? I think really for us in the critical care austere environments, EMS, interfacility transports, we may not have all these fancy tools. Really what you want to do is avoid overt hypotension in these patients, right? There's some famous studies out there that one episode of hypotension in a TBI hemorrhagic patient increases their mortality to about 55%. So just looking at that, that tells me maybe it's not trying to get the specific number right, but just avoiding hypotension. In the same way, looking at cardiac arrest resuscitation, we were so focused on hypothermia for a very long time, right? And now it's like we just want to avoid hyperthermia. So I think we're seeing a same signal here, right? Just hypotension is really bad in these folks. So maintaining normotension or at least a normal map. I don't necessarily think my interpretation of the literature that we need to be so aggressive that we're making these folks too hypertensive, that then we're getting the deleterious effects that we don't want with the permissive hypotension of shock resuscitation, right? So like we get that fibrin mesh layer when someone's bleeding. If we get the velocity of the blood going too fast with the high blood pressure, that could release that and then the patient keeps bleeding, right? So I think there are trade-offs here. And what I teach most of my crews and my own personal resuscitation goal for these patients is yes, there are these guidelines out there that the ideal thing would be a systolic blood pressure above 110, a MAP above 80. But realistically, the big take home for me is avoiding hypotension in these groups and doing my best to maintain them around a MAP of 80 or a systolic blood pressure of about 110. I hope that was a decent enough answer for what I think is a really complex question.
No, it was. It was absolutely comprehensive. No, absolutely, absolutely. So we had a few guests on the podcast recently, Mike, speaking to, a shift in a paradigm really, and the shift for the bleeding patient or indeed the trauma patient, instead of airway breathing circulation, it was access, blood, and then chest. Getting large bore access and maybe even femoral access, but
Mhm.
then giving blood and then chest, so decompressing the chest and then looking and also looking into the chest, doing a fast exam and really sorting the chest out. I guess on the back of that statement, could I get you to speak to, because in this case you denote the fact that the crew who didn't have blood gave
Mhm.
saline, gave sodium chloride 0.9%. Could I get you to maybe just unpack for us, if you haven't got access to blood, is it still a preferable agent of choice to give fluid?
Yeah, so I think that's also a great question, right? And in my opinion, I think yes to a point. In my opinion, again, looking at the overall abundance of data and especially a lot of the new pre-hospital blood data that's coming out, which is so exciting. I think a reasonable bridge is to really cap it at a liter. So my personal practice and what I tell my crews and the way I do it clinically is if I don't have blood available immediately for me, but I have a crashing patient in front of me that needs some element of resuscitation, right? And I'm not talking about the guy who's completely exsanguinated, you get on scene and this guy's not resuscitatable. It's there's a patient in front of me that's about to die and there may be some bridge to blood therapy shortly arriving. So, what can I do to stave off death? In this case, and it's really just providing some element of just pure volume expansion, right? So, I know crystalloid's not what they need, but keeping some volume in their tank will keep them from being dead, definitely. We cap it generally about 1 liter. And my rule of thumb is to give it in about 250 milliliter aliquots. Again, that may seem small, but when you're talking about most of these patients, ideally have some element of large bore access, either through IO or intravenous, and depending on your level of care and service that you're providing, like you were saying, femoral access in some cases. So give small aliquots of 250. You can always give more than that, but then cap it at a liter. And why? We know dilutional coagulopathy is a real threat, right? I tell my crews this. I remember being a brand new paramedic and I worked in a very not nice area. And one of my first traumatic arrests with this guy who had 13 GSWs, and we got a pulse back on him. I remember putting IOs in this guy. We're taking him to the hospital, and I gave him 4 liters of crystalloid before we even got to the trauma bay. And I remember thinking in my head, wow, I just saved this guy's life. And then I go back to check on him an hour later, and he ended up, this is where I learned about abdominal compartment syndrome. He ended up developing abdominal compartment syndrome and dying. And that's also where I learned that, right, we can overflood patients in acute extremis. So there really is also a harm most of us don't think about. The reason I share that story is I always like to think back about when I was a paramedic. What about that patient? It's 3 o'clock in the morning. Med control may not, here we have what's called online medical control. A paramedic can call to get a doc on the line. Sometimes the reality is, and I've been there, the doc is sleeping, not waking up. So what do? It's 3 o'clock in the morning. I have a patient. I may not have blood available to me. I only give them a liter. Then the question becomes, is it better to let them bleed out and die, or do I keep pumping crystalloid in them? AKA, is it better to show up with an exsanguinated patient to the emergency department, or is it better to show up to the emergency department with a patient with a lot of crystalloid in them? My opinion and take on that too is if you're stuck truly between a rock and a hard place like that with no blood product available, I actually make the recommendation that you should withhold further crystalloid administration, and it actually is better to drop off an exsanguinated patient so they're not overfull of crystalloid and you're fighting against yourself. Because we know large volumes of crystalloid resuscitation have such a deleterious effect on trauma resuscitation that I would almost rather have a patient with nothing in the tank and I can give blood where I have blood versus now I'm trying to push out all of this normal saline or whatever isotonic crystalloid solution I'm choosing, and the blood is not able to fully take as effect. So again, really complex situations that just based off how rapid a lot of the advances in pre-hospital medicine are going that we've never really thought about before, right? So, I think in my opinion, again, in my read of the literature, take home is you don't want to demonize a crew for doing what they think is the right thing for the patient in that right moment. And I think crystalloid is absolutely a reasonable bridge therapy, emphasis on bridge therapy. Same thing question comes up too sometimes, is a pressor okay in hemorrhagic shock? And I also think yes, with a huge caveat of it's a bridge therapy, right? I may give a squirt of push dose if I'm 2 minutes away from definitive blood therapy, or I know the responding unit with blood is 2 minutes away, just to maintain that map until blood can get there. But, having a patient on high volume crystalloid resuscitation in the absence of blood or high target pressor therapy in the absence of blood, I don't think is the right answer. So again, this is another one of those, it all depends, but I think as long as the rationale is reasonable, yeah, crystalloid is okay as a bridge.
So let's just look at the fundamental flip in a crew's mind, when blood is accessible, and that flip and that transition to damage control resuscitation and just actually number one, as you were saying before, just declaring that this is a critical care patient, in the pre-hospital arena, and some crews and indeed some teams do have access to blood, both in the UK and obviously in the US as well. But
Hmm.
just declaring the critical care patient, but then almost to your point, giving them a bundle of damage control resuscitation, because you can see there is hemorrhagic shock, there is obstructive shock, there is the potential for TBI as well. There's also the potential for hypothermia, keeping this patient warm, crush physiology occurring as well. So, just walk us through that, just that mental flip to really trying to get ahead of the curve into what is fundamentally a dying patient.
Mm. Yeah, I think that's a great question. Um, so I think this focuses most on the blood portion of damage control resuscitation, right? So damage control resuscitation, I always also like to teach, is not just necessarily about the blood. It's about not undoing the patient's own clotting work, right? So we want to limit crystalloid. We want to limit cold, like you were just saying. We want to limit acid, right? So it even begins before we even get there. And I'm very I'm newer to this area where I'm currently practicing, and the nurses and the medics are just getting to know me. And I promise this makes sense about how aggressive I am with some of these things. Any trauma patient, even if it seems like a BS trauma patient, I'm throwing a warm blanket on them as soon as they hit the ED doors, all these sorts of things, right? Because it's not really until I do my assessment and I have my evaluation of them do I need to know if they're doing damage control resuscitation or not. So there's small wins we can do even ahead of time, like making sure the patient's warm, limiting crystalloid, right? I don't know how it is in the UK, but I'll tell you here in the US, this is a very common thing. Patients sick, patients anxious. We always like to help them. So what's easy things we can do to help them? Supplemental oxygen and a little bit of isotonic crystalloid. It's a very common reflex here in the US, right? So stop that reflex. Don't give every single trauma patient isotonic crystalloid just to make them feel a little better and you feel a little bit better, right? Because even though we may not know if we're in damage control resuscitation part or not yet, that's a limit we can already put on ahead of time. So then the question really becomes, right? So those are more systems level thinking things, right? So what about the individual clinician? Okay, so I have my trauma patient in front of me. I originally did not think is a severe critically injured trauma patient in front of me. What triggers me to switch into blood mode of that damage control resuscitation? And I think in the pre-hospital environment, there's really three triggers I really look at. And again, in a trajectory and data point trend wise. Is their shock index elevated, right? I think that's the easiest win for a lot of us in the field. There's lots of different activation scores out there when we're looking at mass transfusion protocol, and everyone's trying to like, how do we apply these to the field, right? Sort of like trying to backwards do it. There's the ABC score, TASH is out there, but I really think shock index plus mechanism is enough for us to say that's a really pragmatic field trigger, right? And that's where I could say, okay, shock index plus the other things in that shock bundle. And really the two big ones from that shock bundle I'm looking at are the end-tidal CO2. Is it trending down? And that's really showing me, is there a cult acidosis developing? There's a study out there that I'm forgetting the name of off the top of my head, but it looked at in non-respiratory patients, so these sorts of hemorrhagic shock patients. If I have an end-tidal CO2 that sort of equates to a lactate of around 4, in the hospital. So I know that an end-tidal CO2 in the right case could actually portend quite a significant acidosis. So that's another one. And then getting back to mental status. A mental status change I can't attribute to drugs, alcohol, or a head injury may sometimes also be from a bleed. Are they becoming hypotensive because they have a rapidly developing subdural inside or an epidural hemorrhage, right? Take this case. The guy had brief loss of consciousness, then regaining of consciousness. An epidural hemorrhage is something that was very saliently on my mind the moment I opened up this case to review it. So is the patient hypotensive from that? So lots of different things. So I would say, again, just covering my three field triggers is that shock index rapidly rising or changing, an end-tidal CO2 getting a little bit more acidotic, and really less than 30 is my personal trigger, and then a mental status change that I can't easily explain away.
Yeah, listen, that's fantastic. Absolutely fantastic. So progressing through, Michael, and just looking at decompressing the chest and looking at that evolving tension pneumothorax, could I get you to speak to, just that serial reassessment? So because, to your earlier point around numbers, no number in isolation is a value. It's about the trend. And no assessment in isolation really is a value. And it's about that trended serial assessment to get a baseline or indeed an idea, and then the progression or deterioration from that baseline. Could you speak to that?
Yeah, so I think excellent question. I didn't put it in the Substack piece I wrote, but my answer to this actually too is just speaking about the lung sounds portion of it is ultrasound. I really think that's probably the biggest game changer. In my opinion, I think we're actually at a very exciting inflection point within pre-hospital medicine worldwide. For years, it's been a slow progression climb up of really cool intervention techniques, and I think we're just about to hit the exponential rise with a lot of technology that's now becoming accessible to EMS clinicians. And ultrasound really is a game changer for this particular one, but I'll touch on that more in a second. But really, to what you were getting about is the serial reassessments. That first exam is just a snapshot. And really, that fifth exam now sort of gives me a movie I can look at, right? So, initially this patient was this way, but now I've seen how this patient has evolved over. So, in higher energy trauma, too, we really say at minute zero, lots of interventions really aren't happening based off that exam, right? I mean, sometimes they are. We show up and a patient really is at death's door and we're doing things. It's usually some developing exam over the 15 minutes then drives an intervention. So, really my take home point for this is you need to always be serial reassessing, and these are things more so from a systems perspective, right? So when I talk to other medical directors or when I'm writing a guideline or I'm teaching people or we're coming up with, how do we want to teach our clinicians to approach a trauma patient, you sort of alluded to this earlier, right? So like setting the NIBP or the automated BP to go to Q1 minute or whatever, those are systems level interventions for trauma care that can help prompt us to do a reassessment, right? So small things like that I think reteach us to do a reassessment. Like I know, okay, the blood pressure machine is going to automatically recycle every 5 minutes. So I know at that time it's going to be my trigger to reauscultate lung sounds or redo a POCUS or a re-rush exam this patient or whatever sort of trigger it is for you to have. When we're talking about pneumothoraces in particular, I think lots of things are interesting about them in particular, but the serial reassessment of absent lung sounds is obviously the big one. Absent lung sliding on an ultrasound is the most sensitive thing, in my opinion, in the pre-hospital environment to tell us there. Really late term things, hypotension, JVD, tracheal deviation, those aren't as sensitive as we think they should be and not as good of a trigger. But it's just making sure we're doing those serial reassessments on some sort of timely basis, because I'll tell you, that's not even a pre-hospital problem. That's something when we look at even hospital literature for, where it's very hard to do sometimes. So my answer to that is looking at that, right? We know in hospital, out of hospital, it's a very hard thing to do. Systems need to sort of preempt that and figure out some ways and guidelines, or from a medical director perspective, how do I operationalize a reassessment? So it's usually by triggering the system in some way, shape, or form. I know I'm going to get Q2.5 minute blood pressures. So I know with every new blood pressure, I'm going to reauscultate lung sounds, something along those lines.
Yeah. So just looking at the use of opiates in trauma, there is a hesitation to use agents like fentanyl in shock. But could I get you to unpack for us and indeed maybe walk us through your framework for giving fentanyl safely, really, without making clinical deterioration worse?
Sure. This is something I'm actually very passionate about. I'm not all about, I don't want you to get the perspective that I'm about making my patients, zonked or whatever. But in my opinion, I think in the US, obviously, we've had this opioid epidemic, which thankfully appears to be just coming down. And that was largely driven too by the healthcare system treating pain as a vital sign. And I fundamentally disagree with that, except for certain cases such as this. And not necessarily as a vital sign, but I think from a humanitarian perspective, I just don't like this philosophy of a patient is too sick to get analgesia or too sick to treat this. I mean, these are really, when we talk about the post care of these patients years down the line, this is what drives PTSD. This is what drives, poor integration back into their daily living, in my opinion. So being aggressive about analgesia up front is just good care, in my opinion. And we know we have things that can treat the negative side effects of these things in real time. So I'm very upfront about aggressive analgesia in these cases, because untreated pain is in and of itself is a hemodynamic insult. What do I mean by that? Someone's in pain, screaming out of pain, 10 out of 10 pain with a legitimate mechanism, pelvic crush. right? They have a catecholamine surge initially from that, which could be effective as any opioid. These are how these patients walk on a broken ankle or broken leg, right? We've all seen some phenomenal stuff where, like, how did somebody do this? It's that catecholamine surge. Once that catecholamine surge is done, then they're feeling everything. And that sort of works against you too. Worsening pain can drive worsening acidosis. They're screaming, they're bearing down, they're driving a lactate. As emergency clinicians, we've all seen a patient who's been in such psychiatric extremis that they've bumped a lactate, right? That's not a fake thing, that's a real thing. And I think that also contributes to trauma mortality. So I'm very aggressive about getting safe analgesia in these patients. Realistically, is fentanyl going to tank your patient's blood pressure? No, in my opinion. It's a fairly safe opioid when we're looking at synthetic opioids. What's another great choice we have in these patients too? Ketamine, right? Ketamine is a fairly safe agent in these cases, with the exception being, right, this recent study just came out looking at, okay, catecholamine depleted patients may cause cardiovascular collapse with ketamine. So, maybe not as safe in this population as we did have, but I would say even in both those answers, we have blood product we can give this patient to help resuscitate. And then realistically, a small episode of maybe even transient hypotension from fentanyl or from ketamine can be really addressed by epinephrine. Now, you may say, okay, Mike, you just said no epi or, epi in certain cases with shock and all this. It depends what physiology I'm treating it for, right? So epi for hemorrhagic shock and exsanguination, absolutely the wrong answer, right? Epi for transient vasoplegia that may happen from opioid administration or analgesia, epi is the right answer, right? Blood's not going to make those vessel walls tighten up all of a sudden. Epi will. So, I think being able to respond to any sort of negative side effect from the analgesia is the right answer, aka having a push dose pressor ready to go if needed. But I don't think withholding analgesia is the right answer. I think it's a humanitarian issue for our patients primarily. And then number two, like I said, I do actually think it can worsen the lethal triad because we have seen patients in just anxious extremis bump a lactate from bearing down, from causing acidosis. So I think not treating pain can actually cause a lot of secondary effects in the trauma patient.
So just as we're coming to land on the conversation, a couple of more questions. One would be, the atypical or use of, or indeed the adapted use of in this case, in a KED, so a Kendrick extrication device, as a temporary pelvic stabilization tool. Could it just speak to maybe, using these devices maybe away from their initial causes or indeed their initial indications, but to affect within a critical care patient who has been trapped?
Yeah, so great question. I love stuff like this partially because I'm an implementation scientist and that's what I look at, right? So how can we have stuff we already do and use it in novel ways? Number one, but number two, this is just something for me personally over the 20 years of my career in emergency medical services that the KED has had a love-hate relationship with it. We almost used it exclusively on all MVCs when I was a brand new EMT, and now we don't really touch it at all. But does it work for this sort of thing? And I think absolutely yes, it does. So commercial pelvic compression devices or the circumferential compression devices absolutely are the standard. I don't want folks getting away from that. They are. But, with an engine sitting in someone's lap may not be the easiest thing to get on. This crew did a fantastic thing. I'm not sure how it is over in the UK, but in the US, the KED or the Kendrickson extrication device is commonly taught as a secondary means. You flip it upside down, you can get pelvic stabilization from it for your elderly fall victim or something like that over here. So I'm very proud of this crew looking at this patient and going, I'm very suspicious for a pelvic injury. What's a decent way we can stabilize the pelvis in the vehicle and get this patient out without rotating or rocking the pelvis too much? And I actually think the KED was an excellent answer here. If you could fit a commercial binder in there, absolutely. If not, I think figuring out other ways to stabilize it is 100% the answer. So if the KED works for you in that particular instance, use it. So my take home answer for you is the KED seemed to be the right answer in this case. I think any means of stabilizing the pelvis is the right answer, but not doing nothing is not the right answer. So I think even recognizing what tools we may have in our toolbox, if we recognize a novel use for it and a use that we know will help to deter patient deterioration, I think that's a good answer for that.
So just as we wrap the case up, actually, Mike, there was two fundamental decisions really about this critical care patient that maybe made the decision, or indeed affected survivability and mortality, indeed. And that was really to bypass the local hospital and go to a specialty, it's like a level one trauma center or major trauma center. And the other was to go by ground instead of by air, maybe to shave minutes off that loading and unloading. But could I get you to maybe speak to, those decisions that are made in the moment, but actually can really alter the trajectory of care?
Yeah, so I think those are also excellent questions. And I think my take on it is that a lot of these guidelines, when they were written, even if you look at fairly recent studies, 10 years ago, some would say would be recent studies at ground versus air transport, in particular with the US, and I'm sure same thing in the UK, I would say the field of EMS has changed so rapidly in that time that I don't even think that that applies. There's one study I look at by Galvagno that came out in 2012 in JAMA, and it looked at HEMS agencies responding to scenes and does that critical care expertise portend a mortality benefit? And essentially what they found was that mortality benefit and the speed at which getting to those patients to trauma center actually attenuated out when you had a ground crew that was just as clinically capable within a reasonable distance as well. So what does that tell me? Now we have an EMS system 10 years later, well, looking at this study 16 years later, or whatever, math is hard, 15 years later, right? That is significantly more advanced. Blood product, right? At a minimum, that's one way of significant leap, not even just talking about how our clinicians are trained, right, to really look at these patients and treat these patients. Does the expediency at which we get them to the trauma center actually matter that much versus the necessary care we get to them as much faster? So I think that's one question that still needs to be answered. My take home points for you, or my take home answers for you, are when do I think it's reasonable to tell a helicopter no and proceed with ground transport? If I know I have a perfectly clinically capable team with all the things I need, blood, RSI, all those sorts of things, and the ground time is equivocal. What do I mean by equivocal? I'm only going to be saving about 10 to 15 minutes. I think it's reasonable to go by ground. If that helicopter is going to be bringing me lots of things that I don't have that this patient needs, right? Blood, RSI in some cases, right? In the US, not every EMS agency is fully RSI capable, can handle all airways. That's a thing that's changing, but that's a reality of our system of care. So sometimes flight actually is the highest level of pre-hospital clinical care. And I think that is a reasonable question too. Is the flight team going to be bringing blood product and RSI? I think that changes those things. But definitely, if we're looking at a transport differential of ground by air of greater than 15 minutes, definitely 25 minutes, that is a no-brainer that air becomes the safer option for that patient to get them to definitive care faster.
Yeah, listen, that's fantastic. Absolutely fantastic. Mike, listen, it's been a pleasure having you on the podcast. We'll put the link to the Substack case study in the show notes. So it's a fantastic case to really go away. And you do, like you said, you really unpack shock index and all the elements we really spoke of in the last hour. It'd be fantastic to have you back on the podcast for another case study. But listen, thank you so much.
Happy to be here and glad to talk with and meet some folks.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.